Right, okay, ready to get started? Hope you had a lot of carbohydrate for lunch and you're ready for a good nap now, all right? I'm James, James Scrimshaw. I'm a chiropractor by trade, 28 years experience in private practice. In that private practice, I've owned a group of clinics, and I got out of that group of clinics about almost 10 years ago now, and I went back, I set up another sports injury clinic, but I then set up pretty much a sole trader clinic, which is just me, which is so much simpler and not the staff hassles. And then I then started to age, so I got an arthritic knee, diagnosed with by a surgeon, couldn't do anything for it. I'd seen Liz on LinkedIn, so LinkedIn does work, and met with Liz and Charles, and the rest, as they say, is history. I got the device, and I've devoted the last 7 years of my clinical life to understanding and learning the art of using MBST. I've not convinced myself it works, although at times I felt like I was, but actually the results speak for themselves. They've convinced me, and I'm extremely excited and proud to be involved with this technology. The things that excite me about it, well, I first of all owe my health to MBST, my arthritic spine, my arthritic knee, that of my parents, family, friends. When I first started, I thought, I'm going to test it on everyone. I don't want to be the guy in the corner of Westbury, the crazy guy with a machine that he thinks works and it doesn't. So sports players, anyone I knew who would say yes or no, I tried it on, and it just proved me right. It's really exciting, and even more exciting now. So I owe my health to it, but then the results I get from my patients are remarkable. Day in, day out, my practice has grown, momentum has built over the last 7 years. I started slowly, I kind of tiptoed around it, tried it here, tried it there, took on advanced patients and, saw the miracles, started to see the limitations, whereas now my practice is thriving with MBST patients, and then the hands-on care filters in around it. Still very much a chiropractor as well, so I love doing that. I'm very excited about the business aspects of it. From a clinic perspective, from a bottom line perspective, it's very exciting, especially when momentum starts to build. So that's something that we can't ignore. We love talking great results, it's amazing, but when the results start to be referrals, and things start to move, it's amazing for your business. Equally, I'm even more excited now that we've got Charles and his team at the helm. I feel very optimistic. We've always had Liz and Charles supporting us, and they've been so diligent over the years. To have this new energy and focus from Charles is amazing, and the rest of you guys. One of the things I love about working with MBST is the opportunity, the challenges, the highs, the difficulties, they make it worth it, and the people, without getting too sentimental too early. Okay, so it's worth mentioning I'm a practitioner. I didn't invent it. I'm giving you my appraisal of it, and it's my own personal journey. We all go on our own journeys. You may agree or disagree with what I say, but I'm the one stood up here. So yeah, fuck on it. Right, so where it all started with me, the challenges we take on a brand new medical science. It's a new method of patient analysis and the application for treatment for thousands of conditions, most of whom are chronic at this stage, yet we don't do a 3 to 5 year degree in it, do we? We take it straight to market. We charge decent money for it. We'll get to that later. I think the money's fine, but straight to market. And it's quite a significant shift from our day jobs. And when I kind of wrote this, I thought, it's quite a big undertaking. I've got a patient of mine, he's the coach for a couple of really, really world-class rugby players, Johnny Wilkinson, Johnny Sexton, and he says, no one buys green bananas. You always want to buy it when it's all perfect. And actually, we are green bananas when it comes to this. And we've got to put the time and effort into ripening. And then we'll go brown and mushy, but we'll be really sweet. That's where the analogy goes a bit wrong. I was questioning whether I was actually going to say that, but so how to use it clinically? That's one of the main challenges. Which patients need it? How to give patients the confidence to invest in an unknown and broadly unresearched, certainly to the satisfaction of the UK market, technology. How to talk about the machine. To begin with, I only really have my own personal experience and that of second-hand case studies. That's where we started. I was one of 3 in the UK. And then there's how to deal with and monitor the huge variety of outcomes. At the moment, most patients come to us after quite a long journey of suffering. So we need to know when to suggest MBST as a course of treatment, and this will depend on a number of criteria. The main criteria is fairly black and white. It's quite binary, and that's structural change or deficit, the diagnosis. But the more I used the technology, the more I definitely developed an instinct for it and a feel for the technology as to what was the right approach for the patient. But the reality in the UK certainly is that we are kind of doing it the hard way. We're treating mainly kind of moderate plus degenerative conditions, and we're still getting great results, which is really what's exciting about the technology, because what happens when we're able to apply it earlier? We know how it heals at cell level now. It can only be good, can't it? Some patients will be early in their condition when they come to see us. My experience of that, athletes, short-term injury, etc., meniscal injuries, I've seen them disappear in 2 weeks in rugby players, from tear to no tear 2 weeks later. I don't have that as a case study, I'm afraid, because they keep everything to themselves. And ligament injuries that 2 or 3 weeks later have just got full strength back to the joint, even on resisted testing. Others will be 25 years into their diagnosis. And some of this group will be expecting a miracle, whilst others will be just looking for a mild to moderate swing in the right direction. And that would be a great outcome for them. But for me, 7 years ago, choosing the right treatment was obviously the biggest learning curve, and it still is for us all. I was using single treatment cards and had some great outcomes, but the more complicated cases with multi-tissue pathologies, I was getting more watered down responses. So then the next stage was learning to use MBST in combination. And I found that the combination cards was a bit of a breakthrough in stepping up my percentage success rates, and still is. So it just makes sense. It's a logical progression. Before we get going, I wanted to kind of save us all some time on the UK WhatsApp group and go through some of the conditions that MBST doesn't treat. Gout. Human African trypanosomiasis and most other tropical diseases. Submental mandible, aka double chin, it won't get rid of that. Lactose intolerance, which is the intolerance of people with lactose intolerance. Unfortunately, it doesn't treat hangovers, so we've got to ask MedTech to get to work on that, please. And this is one I thought about. Fecal encephalopathy, also known as shit for brains. And it's unlikely we'll get a device in the House of Commons. Boom, boom. Right, that's the highlight. It's downhill from here. So, growing an MBST practice. As practitioners, we're the ones at the coalface. We're delivering the product to the patients. And growth starts and finishes with us. Learning, trying things, understanding it, studying it, practicing it, recommending it, having the conversations when you don't really feel like it, learning from the outcomes. It's all about the practitioner. If you run a clinic treating orthopedic injury, there'll always be opportunity for MBST to help the patient. But you need to have the conversation about how and why in order to get it going. And this is the foundation of growth. Another important foundation is that you have to stay really close to MBST and the patient journey. You have to get in and amongst the case. You have to walk with the patient throughout the outcome. Success in using it doesn't come to you. You've got to apply yourself. We're studying it. It's a new science and art. But it's not easy, but after a while it does become behaviour. It's certainly not a sideshow or a money spinner, although, like I said, business-wise it's great. But if it's one of numerous things in your practice that you offer and you don't give it the time and focus that it needs, it will lay dormant in your practice. I know, I've been there, been distracted. Life, other things. In some cases, it takes time to throw yourself into it. Some clinics hit it hard from the word go. I know Oakwood and Ian just went hard straight away. And others build gradually, and momentum does build. But the more you use it, the more instinctive you'll feel it, and the more knowledgeable you'll become, and more natural it will become. Practitioners we have to work on our mindset anyway, but in particular with MBST in our conversations, we really need to focus on the clinical successes you've seen. And please don't belittle the responses we get. Even the minor changes, they mean a lot to patients. Don't belittle it. See them as remarkable. I explained MBST to a friend about 8 years ago, and I said it's a machine, and you don't see it, feel it, hear it, you lie in it, and it heals arthritis and regenerates cells. He told me to fuck off. It wasn't very nice. However, it kind of says it all, really. It is a remarkable technology. And one thing that drives me, the reason I'm going on about it, is that finding that passion does drive your practice and your growth and your immersion in it, and it all gets better. But you do need to be determined and committed and fearless, or go through the fear of recommending it. Maybe you've seen a bad response, or but then think what a surgeon has to go through. They'll ask £15,000 for a knee replacement with a huge variety of risks and variable outcomes. Yet it's accepted, and regardless of the outcome, they'll turn up the next day and do some more operations and get on with their day job despite this. And we need to do the same with MBST. We're all in communication about what it treats and what it doesn't treat, but there are variables, and a lot are amazing, but equally we need to kind of suck up the ones that aren't and learn from them. The practical aspects of marketing your practice I won't go into. Adverts, events, social media, talks. There's no doubt these are very important, but getting your dialogue and conversation right is key, and that will filter down through all those mediums, make them much more effective. A business needs constant sales activities to succeed. The main tool in our business is conversation and delivering that information, be it to patients, be it to doctors, be it to sports clubs. And it does take time to learn and relax and know your subject when talking about MBST. It is a new science after all. So the things we need to cover in conversation, and forgive me if I've missed something, is what is MBST? How does it work? The benefits and potential outcomes are key. Always try to draw from positive experiences when talking about MBST. Of course, then we have to bring in realistic expectations and limitations based on the case. But the majority of cases we treat do respond, unless you're taking on the wrong patients. The research is also crucial, the scientific research. And we have got an increasingly valuable portfolio of research to draw from. And we're entering to a stage where we've got much greater credibility in talking to the medical profession. Whether they want to listen or not, we have scientific basis of how MBST works at cell level. So ego or not, we have it. So we should have a bit of an ego about that, don't you think? I personally think so. Length and cost of treatment is obviously a conversation we need to have. And then the diagrams and models when explained to the patient, I think, are really important as well. Schwann cell diagram, the 5 stages of the degenerative process. The more detail the patient understands in terms of their pathology, then the greater understanding they'll have in why you're applying the technology to that pathology. And they'll be on board, and it'll make this a smooth journey for the treatment process. So talking about MBST, I think we all need to master talking the simple science. So that cell study that Charles talked about today, just broken down into a very simple way. Being able to talk about it at cellular level with confidence is really important. You need to find the right hooks in your story as well that feel right for you. Personal story and emotional connection is always better. I don't know how this works. Well, I do, but I just don't know the order. For me, it's having successful case studies at the tip of my tongue. Always have a case study at the tip of my tongue. My own and those of my patients. Then you've got to temper it with the reality and the limitations and the severity and the history and the patient's lifestyle. Optimism with transparency is something that kind of goes round my head. You have to be really transparent and legitimate, yet with everything we've seen, you can recommend it in most cases. Obviously, there are cases where you just don't recommend it, but the majority of cases, I feel MBST can add an ingredient of healing. The chat doesn't happen overnight, and even now I trip over myself. The more you think about it, the more you work at it, the more passion and conviction you get from working with it, and the more comfortable the conversations become. But it does all boil down to the application of it. So breaking it down even further, speaking with authority, showing your knowledge, showing your experience, and bringing their reality and case limitations in, and finishing with confidence. It's a bit of a structure that I have in my head when talking to patients. So an example of my chat is, after assessing the imaging results and appraising your case, I'm confident I can help you here. We know MBST works at cell level. It's no longer theory, but it's fact, which explains why we're getting such great outcomes. Treated Mrs. Jones with the same condition as you, or very similar condition. She had an amazing outcome. I do operate at a 90% success rate, and there is no risk or side effects. Having assessed your case, I'd be really surprised if there wasn't a response to be had here. So that's that one. Examples, obviously. Scripts I don't think work, but I do kind of tend to say the similar things each time, but it does vary. More complex cases are, this case is very severe, advanced or complex. However, I've helped numerous cases like it before, but in this case, I'd probably say it was 50-50, 60-40, that you're going to see an outcome. Sadly, in the medical profession, there are no guarantees, but if there is any potential to heal, MBST will find it. Chris and Lucas had stage 4 arthritis and responded really well, and they're still going wrong years later. However, some were less responsive. Every case is different, but the only way we really know is to try. And some do, and some don't. It's their personal decision. Less is definitely more. Keep it basic, and it's easy to tie yourself in knots. But it doesn't really matter. Take the pressure off yourself. Just try. It's all learning. Other things I say, simple science, MBST resets and resynchronizes the abnormal elements of stressed, inflamed or dying cells, leading to a recovery of the cell and production of more cells. This permeates through into tissue recovery and then an outcome for the patient. This process takes time, so we need to be patient. Sometimes the damage is so severe there's not enough tissue change to come through as an outcome. We don't 3D print new joints. It starts with cell healing and builds from there. Choosing the right patient is another thing to consider. A lot of patients are really severe. We do attract them with adverts and stories of miracles, and you get cases that are due surgery next week, and some do respond. But setting the expectation at that initial consultation is absolutely crucial for the practitioner and the patient as well. Equally, learning to talk about the treatment costs is very important. Be bold. You've got to look them in the eye. We add overhead to our businesses, and the financials have to overcome the months where you're quieter. I've got 3 machines, several rooms, a couple of technicians, and also I'm allowed to earn a little bit of money, for my time. In terms of overcoming the barriers to purchase, don't let the barrier be you. The patient's the boss. Let them make the financial decision. It is expensive in some terms, but we're selling something that, in my experience, changes the majority of people's lives by safely healing or regenerating new tissue, and the benefits last for years. It's using expensive MRI technology. So I say to patients, it's not going to be £100, is it? That's the price of a physio appointment in London. So I feel the money's about right, especially for the benefits that I've seen over the years. You've got to feel that yourself, I think, to be able to go forward with that, especially when selling multi-tissue cards, cases, you know what I mean. However, understanding it's a big investment for some patients and their weight of expectation can be really heavy. And I do tend to spot these patients for whom it's too heavy. They and they are, or they vocalise the fears of non-response or talk about money a lot. And I tend to steer away from these patients. They're high anxiety and tend to microanalyse. And in the end, I just tell them if I feel the stress is too high, that it's probably not right for them. It's just too much pressure all round. So aftercare and rehab. So we do encounter a huge range of outcomes, from the miracles to the great responses, to the slow responses, to signs of change, to very slow responses, abnormal responses, which are rare, and then the non-responders. Just touching on abnormal responses. I feel like, I've seen probably 1,500 patients or so in my time. I think, though, I've probably seen one or two where the knee is kind of blown up when I was treating, not actually physically blown up, but it's just deteriorated. And I feel that there is a natural progression at some points where it's going to go off a cliff. I personally, with the number of cases I've seen, I feel like it's a bit of bad luck. Unfortunately, when it happens at the same time as they start treatment, the patient's not going to see that. And you can argue until you're blue in the face, but I believe that. And then you've got the aggravation of sitting on the bed. If you're doing a double card, you've got 18 hours of sitting on a bed with an arthritic condition. It takes you an hour to get there and go home again. So that's 4 hours a day sitting with arthritis. That's nearly always the reason why patients kind of feel a little bit more pain, in my opinion. And then you've got high anxiety and slightly mad patients. I'll come to those in a minute. So barking mad. So follow-ups for good initial responses, I personally tend to leave them longer. I let them enjoy the benefits of choosing MBST. It also gives MBST a longer time to establish healing, so that when you actually do start your rehab or hands-on care, there's better neurology in the joint. So you're likely to get a better outcome from the hands-on care. And I feel this approach also lets MBST shine. And this is a lot of the cases I treat. I'd probably say about 50% of my cases get better within the 9 hours. They get off the bench, they notice some change. The other 50% take time. But it varies. Sometimes it's 30, sometimes I can't put a foot wrong. When MBST is allowed to shine, I feel like it really does breed more referrals. Equally, the quicker responders, if you get stuck into hands-on care straight away, and it's a sensitive case, you can actually aggravate. Done it a couple of times and you're not popular. So you've got to be careful with your aftercare. Things like laser, needling, I'm a chiropractor, so, manipulations are, in delicate cases, unstable cases, you want to be avoiding that, in my opinion. A couple of chiropractors here go, no, you don't. For slower cases, I bring them in earlier. I keep reminding them of the process. Apply the hands-on care, but the conversations are very important because it does take time to come through. So that's where I talk about walking hand in hand with them and explaining the process, what they undertook, the cellular healing, etc. And equally, if you've done everything you can, you've tried, obviously, MBST, you've done the hands-on care, and, if they don't get the outcome, then, they know you've thrown the kitchen sink at it, as I say. And sometimes if you have a run of slow results as a practitioner, you can have a bit of follow-up anxiety. And this can be due to the type of patients you take on. I went through a stage of taking on just the most severe cases, which is why I'm talking about this. And you can kind of feel like you start to question things, and then you start to shift the type of patient you're taking on and the communication, and everything starts to lighten them. I think we all know as a practitioner what it's like. So you have to be careful, but it's also important to understand that patients come to you not to test you or to test the technology, but because they're in chronic pain. And it's very negative for the patient. So there's an expectation to hopefully get you out of that pain. In terms of explaining the slower responses, I go back to the science. You've got a 4 to 8 week healing process, cellular healing process. And then the tissue healing kicks in from 8 weeks on. When sufficient tissue healing's occurred, we have an outcome. and this can take many months. So the causes of non-responders are too severe or complex, which we treat a lot of. Ongoing biomechanical stress, so your job, your lack of rest, overdoing the gardening, etc. Not knowing the detail is a key one. Lack of good imaging and reporting especially. And stress and anxiety and emotional trauma. But you do sometimes get your head scratchers. Sally's a GP who referred me 10 patients from a little village in Somerset, Wedmore. 9 out of 10 of those patients were definitely beyond moderate. And in fact, all 10 were, but 9 out of 10 had amazing responses. This is, I'm talking about the challenges here, but 9 out of 10 got better is why I love this technology. But the one that didn't, obviously, that's the one I'm interested in. I'm delighted for the others, and I'm not belittling the responses I said earlier. But, the question is, why didn't that chap, who he was a lovely guy, why didn't he respond? Truth is, I didn't have an MRI scan for him. So that may or may not have changed his outcome, but I wasn't able to tell him and giving him an indication why. So the more detail you have, the better. I always look for the reasons why. Am I judging it too early? Have we done enough treatments or treated the right tissues? Or is it simply that the patients are unable to pick up metabolically enough to bring the healing through to the tissue? It's as good a theory as any. But if you care, non-responders will hurt. And despite your best intentions and treatment, some patients will be unhappy. So we have to analyse the matter. Was it due to the wrong case or the wrong tissue or not enough tissue? Were they a red flag patient? Were you too enthusiastic when selling the treatment? Is it that the patient hasn't really understood or listened properly to the process? Red flag patients, sorry, going behind. Despite your best intentions and treatments, some patients will be unhappy. So we have to analyse the matter. I've done that one already. Red flag patients. Okay, so these are patients that, these days I'm kind of standoffish with. Anyone who comes in blaming another practitioner for their pain, if they're angry, accusatory, avoid. I've had one guy in the past, he blamed the surgeon for deliberately causing his back pain in an operation. And as I'm saying these words, I'm wondering why the hell I actually took him on as a patient. But I did, and he needed a couple of components, so I treated a couple of components, and guess what? He came at me angry as well, and irrational, and accusatory. Fortunately, I had Liz and Jamie to help me out with that, because, we all care at the end of the day. I had to bite my lip on that one. But it was all resolved, wasn't it? That's my one and only kind of, I'd say complaint, but he wouldn't come in for a reassessment either, and I kept saying, come on in. I don't know if he was taking the mick or not, really there. Psychological trauma is an issue, I feel, but that's only in my limited experience, several cases. Even with the right physical indications for MBST, their response may be slower or more challenging. And high anxiety patients is another challenge. My mum's one of them. She won't go in the OSP because she's got atrial fibrillation. Even though I sent her all the information on the fact that MRI is the gold standard for diagnosing heart conditions. So she's finally sent me a text this morning saying, I'm sorry, I've just got myself into right tears. I'm going to go do the treatment now. And I'm like, okay, mum, thank you. But I've treated quite a lot of anxious patients, and they are more likely to note side effects, be worried about the process, and also want to pull out halfway through. Right, I'm here now, I've caught up. My ex-business partner always said, never apologise. And he's been taken to disciplinary more times than anyone in the medical profession I know. So that's a lesson learned. We need to show we care. I'm sorry this hasn't responded in the way we'd hoped. Let me look at this case in detail. We've got to be open. We've got to show that we're going into this with the best of intention. Empathy is really important to share. But it's also fine to stress that 80 to 90% of cases respond, but that leaves 10 to 20 who may be too complicated, too severe or too far gone for the cell healing to come through as an outcome. If patients truly understand this at the start, they won't have an issue. So we need to make sure we keep great records, pain scores, activities of daily living, and orthopaedic examination. And I am open to keeping the patient happy. Often they're unhappy because they're in chronic pain, not because they're bad people, and they're sad when things aren't going their way. When you're seeing small numbers of patients and you get a number of slow responding cases, that can make you question everything. But I can tell you that feeling is temporary and you will learn from it. Search for the reason. It's nearly always severity that's driven it. Look at your initial conversations and the patients you're taking on. If the patient's not responding, look at the case and speak to the MBST team. Reach out on the app. Ultimately, we're not going to keep everyone happy. But it's also worth mentioning, don't panic. I've seen maybe 1,500 patients. That means I've probably seen 150 to 300 patients that the outcome wasn't what we intended. I have one complaint I've told you about, and I'm getting way more referrals now from the successes than I had in the last year, 2 years, 3 years. I'm seeing 10 times the number of patients I was 5 years ago. So your reputation's not going to be mud, providing the patient knows that you're on the job and your intention is good. And keep talking to your fellow practitioners. A crucial part of being an MBST practitioner is accepting the journey is wonderful with its challenges. You may oversell or forget the follow-up. You might have the miracle or the challenging case, and not everything's predictable. But we need to be brave and recommend it, because it's the majority of cases that will respond. And you'll develop the instinct for the technology, which I think counts for a lot. I use the term brave quite a bit, but it is easy for you to steer away or when you're not in the mood or don't feel like having the conversation. Certain things hold us back, the fear of patient disappointment, your reputation, money, and we all suffer these occasionally. But we got the science, we got the backing, we know the results we get. So it's time to break the shackles. And we need to start showing our excitement for the technology, balanced with good clinical reasoning. Get way more success than not. So I've spent quite a lot of time talking about the challenges. Hopefully it's not too negative. But I know the practitioners, I talk to you all regularly, and to stand here and not discuss it would be disingenuous. But really, this technology is something else. It's changed my life and that of a huge amount of the patients I see. And I'm so excited, especially now. It's worth considering what treatments in the medical world do these patients have at their disposal. Hands-on treatment, drugs, injections, surgery, pain clinics, psychology. And what do? Do they heal? Do they cover up? Do they hurt? Do they work every time? Are the results permanent or temporary? Do they have no side effects? Are they cheap or do they aggravate? Why not MBST in this mix? Based on what we see pain-wise, it heals, it has no side effects. Pain-wise, it gets amazing results. You've got really good odds of success. It's an absolute must now that we start to push this into the medical model. And it's time for us to collectively to roll our sleeves up and get on with it. We're at the forefront of a new branch of medical science. Huge potential, what it's capable in treating. And we are the ones rolling it between our fingers, testing it, finding the limits, seeing the miracles, facing the challenges. We need to find as much passion as we can for the technology. You see the beauty in the nature of what it does. The energy is only 20 times greater than the Earth's electromagnetic field. I remember Charlie telling me that. I mean, that's the beauty is in the nature of what we do, and I love that. And so should we all. And it's a no harm and side effect technology with such profound results. I mean, forget what I'm standing here saying now, we've seen them in the presentations earlier. We largely attract last resort technology at the moment, but I really think last resort cases at the moment, but I really think we need to start banging the drum for early intervention. So if ever a patient says, oh, I might give it some time or wait a year, say, no, you won't. You've got to do it now, because now is the time to treat. So the only thing that's going to happen is that we're going to get better and better. All our results will filter through into the communities in the medical profession, and then we can have the conversations with terms of science, whether people listen or not, whether we get it right or wrong, the way we talk about it. These guys are working hard to deliver us that information. We have to be the ones to go out and talk about it. And that's where our responsibility lies. But equally, I think we need to try and enjoy the journey as much as we can too. But not hide. Accept the responsibility that we are pioneers, whether we like it or not. We have great support from MedTech. The more patients you see, that instinct will come, that belief will come, that conviction will come. Every single new patient that comes through your door has got the potential for MBST to help their healing process. And you need to act on that. They might not be suitable, but the potential is there with everyone. So we're still in the relatively early days, but we've made a lot of progress in the last 7 years that I've been involved. And the momentum is building fast. And for those of us with the foresight to take it into their practice and the conviction to see it through, I think there's every chance we're going to leave a great legacy. Thank you.